Hello everyone. In this video, we will talk about the fungal infection Aspergillosis. The causative organisms for this fungal infection are the Aspergillus species, namely Aspergillus fumigatus, Aspergillus flavus, and Aspergillus niger, with Aspergillus fumigatus being the most common. Now let us look at the clinical features of this condition. Aspergillosis can lead to superficial infections like otomycosis or fungal infection of the ear, keratitis or fungal infection of the eye, and sinusitis or a fungal infection of the paranasal sinuses. The second form of infection is allergic bronchopulmonary aspergillosis or ABPA. It is a hypersensitivity allergic reaction, specifically a type 1 and type 3 sort of reaction. And in type 1, we see asthma. In type 2, we see pneumonitis. What happens here is that the fungus starts to grow in the lumen of the bronchioles of the lung. So the fungus starts to grow in bronchioles, and these bronchioles, they then get occluded by fungal plugs. And when we do a sputum examination, fungus will be present in the sputum. The third type of presentation is an aspergilloma. An aspergilloma is a fungal ball. Now this fungal ball is formed in pre-existing cavities present in the lung. So if there has been a TB infection in the lung in the history, it will form a cavity, and in that cavity there will be a fungal ball production. This might also lead to massive hemoptysis in the patient. Finally, invasive aspergillosis is a disseminated form of infection where the infection starts with a pneumonia, but then eventually it spreads to the brain, to the kidneys, and to the heart. This form of aspergillosis occurs in immunocompromised patients, namely patients who are on antibiotics or steroids or cytotoxic drugs. So, in a summary, these are the clinical features that happen in an aspergillosis infection: superficial infections of the eye, ear, and paranasal sinuses, allergic bronchopulmonary aspergillosis, aspergilloma or fungal ball, and then invasive aspergillosis. For diagnosis, we can use bronchoalveolar lavage as the specimen. This is what we use, and what we see in microscopy are hyaline septate hyphae with dichotomous or acute angle branching. So if we break this down one by one, it means that the hyphae will be hyaline, which means they will be a little shiny, septate, which means they will have these lines in between, and they will have an acute angle branching. They will be branched and they will be present at an acute angle with each other. So not a 90-degree angle, less than 90 degrees. This is how we visualize them: hyaline septate hyphae with dichotomous or acute angle branching. The next method for diagnosis is galactomannan. Now galactomannan is a component of the Aspergillus cell wall. So we will do a galactomannan test, and that will be positive in a patient with aspergillosis. On culture, we see that on Saborod's dextrose agar, all three Aspergillus species will have a different appearance. So a fumigatus, Aspergillus fumigatus, will have a dark green appearance, a dark green colored colonies. Aspergillus niger will have black colored colonies, and Aspergillus flavus will have yellow-green color colonies. Fumigatus is dark green, niger is black, and flavus is yellow-green. We can also do ELISA or PCR for the diagnosis. Treatment is with either voriconazole or amphotericin B.